Hi everyone. Today I'll be presenting our recent study, Frailty as a Predictor for Post-Operative Outcomes Following Pancreaticoduodenectomy. So to introduce myself, my name is Vivian Li, and I'm a Bachelor of Health Sciences student at McMaster University, and I've been working with Dr. Pablo Serrano in the Department of Surgery at Jarvinsky Hospital for the past 3 years, investigating various outcomes following colorectal and hepatobiliary cancer surgeries. But today I'll be discussing our recent study on frailty and pancreaticoduodenectomy specifically, which I've been working on for the past year. And before we begin, I would just like to disclose that the authors have no conflicts of interest to declare. So first, to provide some background, pancreaticoduodenectomies carry a high rate of major post-operative complications ranging between 24 to 60%, including delayed gastric emptying, pancreatic fistula, bleeding, intra-abdominal collection, and pulmonary complications. Frailty has been described as a clinically recognizable state of decreased reserve and function across physiologic systems characterized by an inability to cope with acute stressors. Independent of age, frail patients are more susceptible to suffering adverse health outcomes following surgery. However, there are numerous tools available to quantify frailty. For example, the Canadian Study of Health and Aging developed a 70-item frailty index. Using this model, frailty was quantified based on multiple findings on history and physical examination. Velinovich simplified this model in order to make it easier for clinicians to identify frail patients. This modified frailty index, or MFI, uses 11 items for this assessment and has been shown to correlate with both morbidity and mortality across surgical specialties. Therefore, we hypothesize that this modified frailty index predicts post-operative complications following pancreaticoduodenectomy. So our study's design was a retrospective cohort of consecutive adult patients undergoing pancreaticoduodenectomy between April 1st, 2011 and April 30th, 2020 at a single academic institution. An MFI consisting of 11 variables adapted for the National Surgical Quality Improvement Program database from the Canadian Study of Health and Aging Frailty Index was used. Patients were stratified into two groups, high and low MFI, based on a cutoff of 0.27. Clavine-Dindo classification was used to categorize any post-operative complications within 90 days following surgery, while post-operative mortality was described as death within 90 days following surgery. The effect of MFI on post-operative complications and mortality was evaluated using multiple logistic regression and expressed as odds ratio and 95% confidence interval. Among 554 pancreaticoduodenectomies, there were 64 out of the 554, or 12% of patients with a high MFI. The low MFI group was significantly younger and had a lower American Society of Anesthesia class. Otherwise, high and low MFI groups had similar baseline and operative characteristics, including gender, preoperative albumin levels, body mass index, smoking, chemotherapy, and the proportion of patients with pancreatic adenocarcinoma. This is worth mentioning as it assures that our patient population is mostly similar, except for a higher rate of frailty. However, the high MFI group had significantly longer median length of hospital stay, a higher rate of intensive care unit or ICU admission, and a higher 90-day mortality rate. As you can see in this figure here, linear regression analysis also showed significantly increased post-operative complications, including major complications, as well as post-operative mortality with each increasing MFI score. In this next figure here, you can see that by multivariable analysis, MFI score was an independent predictor for the development of any type of postoperative complications in major postoperative complications. This is generally consistent with the results of prior studies, which have investigated the relationship between some degree of frailty and postoperative outcomes following pancreatic resections, although to our knowledge, this is the first single institution series. However, this study did have a few limitations. So first, as increasing MFI is thought to be associated with increased postoperative complications and mortality, higher MFI groups are underrepresented as those patients are considered to be non-operative candidates in preoperative evaluation. Therefore, the number of patients with the highest MFI was relatively small, limiting our analysis. Additionally, this study is limited by its retrospective nature. We do not know if patients were transferred to the ICU due to an expected higher rate of postoperative complications among high MFI patients or due to the complications themselves. Therefore, those patients would be more likely to be admitted to the ICU following pancreaticoduodenectomy as a preventative measure anyway. Future prospective studies may seek to validate the use of MFI in combination with other risk stratification tools to better predict postoperative outcomes. In conclusion, we believe that the MFI is both reliable and convenient for predicting postoperative outcomes following pancreaticoduodenectomy. It can guide patients and clinicians in the decision-making process by identifying patients at high risk of developing adverse postoperative outcomes before surgery. So thank you for listening, and please feel free to ask any questions at this time or contact Dr. Pablo Serrano at the following email for more information.